I want to just say as disclosure here also that I personally have not done a TAVI in a couple of years now, but I am the assistant director for the unit, and as you probably know, the German system is very hierarchical, so I'm intimately involved in the patient selection process and also in the complication process. So when there's a complication, they call me. The person who's leading our program right now is David Holzai, the second author there. And of course, Fred Moore is my boss. Without him, none of this would have been possible. We do have a very large experience at our center. I think we have the world's largest experience in TAVIs. We're up to over 1,600 currently. And I'm not joking when I say to you that last week we did 14 in 2 days. So by disclosure, I do receive speaking honoraria from Edwards, Medtronic, and St. Jude, but I'm not a consultant to any company. So the surgeon's role in the TAVI, I believe there are 4 main components. This is the most important one, that's decision making. It's the heart team. The heart team has to play a principal role in deciding what is the appropriate therapy for these patients, and in the latest iteration of the valve guidelines from ESC and EACTS, which will be published in September of this year, the heart team plays a front and center role throughout the manuscript, and very clearly stated that an interventional cardiologist, a clinical cardiologist, and a cardiac surgeon should be participating for every one of these patient therapeutic decisions. Interestingly, that's also in the myocardial revascularization guidelines, but that hasn't quite taken off in that area. So another important area for the surgeon is complication management. I do have a talk this afternoon on TAVI complications, so I won't be talking too much about that here. Of course, the transapical procedures, performing the transapical procedures. Having said that, we always have a cardiologist at the table for every one of our transapical, and also for the transfemoral, we always have a surgeon at the table. It used to be, when we first started doing these procedures transfemorally, that the surgeon would expose the femoral vessels under a general anesthetic. We stopped doing that a long time ago, and we basically are doing them under local anesthetic now. And the interventional cardiologists are managing the femoral artery percutaneously. So for the majority of the patients, the surgeon is basically standing there and not doing too much, but his principal role is to take over in case there's a major complication. Having said that, we have started switching roles. So David Holzai, now our surgeon, now does transfemorals, and our cardiologist now does transapicals. As a matter of fact, at our Leipzig meeting last December, our cardiologist actually did a live transapical with David Holzai assisting him. And it went perfectly well. So they're up to, the cardiologist and the cardiac surgeon are each up to about 20 from the cross-specialty procedures that they've gathered as their experience. So as I said, decision-making I see as the most important role being played by the surgeon. And as the surgeon, we must constantly remind our sometimes more enthusiastic colleagues that cardiac surgery has a long history and has very good results. This is a paper that, it's a bit hard to read because it's very heavy in statistics, but as a cardiac surgeon, I think this is a standard paper that people need to know. This comes from Albert Starr's group in Portland. As you all know, he has an extensive, very long history with valve replacement, one of the fathers of this area, and they looked at cost effectiveness for aortic valve replacement over different age groups. First of all, when they compared their long-term survival over 40 years experience in Portland for patients with severe aortic stenosis to various studies, which you see in the gray lines there, that were medically treated severe aortic stenosis patients, the difference in survival is self-explanatory. But this is the important slide here. What they did is they looked at every age group over time and then QALY, so quality adjusted life years. And then they calculated the cost effectiveness ratio, which is the amount of money per QALY. And if you speak to medical health economists, they will tell you that anything that costs less than $20,000 per QALY, which is the dashed line that you see there, is a highly effective, highly cost-effective therapy. And you can see for every age group up to the age of 85, it's a highly cost-effective therapy. And even above that, some health economists use 25,000 as their cutoff, and that would mean that basically even patients in their 90s is a cost-effective strategy for conventional aortic valve replacement. In comparison, you may want to ask, well, what about other therapies like LVADs? Well, that's $100,000 to $300,000 per QALY. And what is it for TAVI? We're not exactly sure yet. There's some preliminary data coming from Dr. Cohen in alliance with the partner investigators. And the cost per QALY is certainly not as high as LVAD, not even close, but it is quite a bit higher than conventional aortic valve replacement. And we also have to remind our colleagues that there are already standard protocols out there in the literature for what the indication should be for these procedures. So patients greater than 75 years of age with an elevated risk score. What exactly elevated risk score means, that's a bit hard to define, but they used in this document STS greater than 10% or logistic Euroscore greater than 20. Other high-risk patients that may not be captured by those risk scores. So, for example, post-coronary bypass with a patent lima, a porcelain aorta, radiation valvular therapy, or patients with cirrhosis. And then a particularly promising group of patients is the last one there, the valve in a valve, but I'll get back to that. Why is that important? Well, this is the reason why it's important for us to curb some of the enthusiasm. As you see, there's been an explosion in these procedures in Germany. We're up to over 30% now of all isolated aortic valves are being performed percutaneously in Germany, and this is not capturing all of them. We also know there's about 1,000 from government data. There's about 1,000 that we're not capturing here that are probably being done in centers without cardiac surgery backup, because this is cardiac surgery database data, which I'm showing you here. So we're probably approaching about 1/3 of them now in Germany. And we also see that in 2008, we hit the peak for the number of conventional aortic valve replacements, and it's progressively going down from there. So there is, I think, some abuse that's occurring in our country, and this is just another way to show that exact same data here. The number of conventional replacements are going down, and TAVI is exploding. And one of the reasons why there may be some potential for abuse is this slide here showing the countries that have temporary funding or DRG funding for TAVI. Of course, in the UK, it's not. There is no separate DRG yet. In Germany, there is a separate DRG, not just for the aortic valve replacement, but you also get a separate DRG for the valve itself. So if the hospital can negotiate a good price for the valve, it's a real money-making undertaking. And as a direct consequence of that, Germany has 45% of all European TAVIs that are currently being performed. And you see here the rates of TAVI per million people, UK on the far left, Germany on the far right. Unlimited reimbursement does matter. So that's just the realistic part of my talk. I also want to show some data that also to put into context when you're discussing what is the right therapy for these patients. So this again is the surgical-based data. All cardiac surgery centers in Germany send their data to this registry. And you see that when you stratify patients' survival for TAVI, either transfemoral or transapical, they're grouped together in this slide. You see that the overall mortality was 8.3%. And when you stratify it by age, you see, first of all, there are many patients that are getting TAVI that are under 80 years of age, and that younger patients don't necessarily benefit from the procedure, although, having said that, they are probably very high-risk patients, the young ones. This, though, is very concerning to me. When you stratify mortality by Euroscore, although the guidelines state that these should be saved for patients with 20% or more logistic Euroscore, you see in this slide over 500 patients, 500 of 1,367. Over 1/3 of patients had a Euroscore of less than 10%. And you can see their survival here was worse than the predicted Euroscore, even though we all know Euroscore vastly overestimates risk. In comparison, if you look at conventional isolated aortic valve replacement surgery, there's a total mortality of 2.4%. Of course, these are lower risk patients than TAVIs. However, more importantly, you see this sort of parallel increase in actual mortality as the logistic Euroscore increases. So that association which did not exist for TAVI does exist for conventional surgery, exactly like we would expect. So there are some elements of TAVI that we don't quite understand, that there's, and I can tell you from a large volume center that does these things almost every day, the thing that really frustrates me about TAVI is that you can do it 15 times in a row and have a perfect result, and then on the 16th one you did it the exact same as the first 15 and the patient dies. And we don't know exactly why in some of those cases, and we need better ways to predict those patients that are not suitable for TAVI. This is also data from the New England Journal of Medicine that was just EPUB a couple of weeks ago from partner B. So this was the group that was randomized to either optical medical therapy or transfemoral TAVI. And what they found is that the very high-risk patients with an STS score greater than 15% did not have a survival benefit from TAVI. And I can tell you that's also been our experience. At first, when we were very enthusiastic about this, we had some patients that were extremely high risk. They would die with a haircut, and they arrested during the induction phase. We went ahead and did the procedure. We did that twice. Both patients died on the table. So if they're so sick that they can't get through an anesthetic induction, they shouldn't be receiving this therapy. And then again, as the surgeon's role to sort of put it all into context, here's an example. This is no joke. This is not something that I picked out of the last 5 years. This is something from this week. This patient underwent surgery yesterday. 72-year-old male, previously very active, was jogging daily, had class 2 symptoms. Notice that he wasn't able to jog as far as he used to be able to. No comorbidities, severe aortic stenosis, bicuspid aortic valve, all the things that would say that this patient should not get a TAVI procedure. What happened? He got a TAVI, not at our center. Got a 29 millimeter core valve in February last year. They injured the femoral artery, required a patch reconstruction under a general anesthetic, and then basically it all ended up to be a sham procedure because he then came to our center with a severe paravalvular and transvalvular leak. So we haven't done this guy any favors with his TAVI. He survived his operation yesterday, by the way. Here's another one. Again, surgeons having to impart our long-standing knowledge in this area to some people that are sort of newly discovering the area. So this is an 82-year-old that had severe aortic stenosis, received an EPIC 19 millimeter valve in 2009. As you all know, the EPIC has the smallest internal diameter of all the valves bioprosthetic valves on the market currently. And this is not the right valve for this patient. He was too big. And it had afterwards patient prosthesis mismatch, which was then managed with a core valve in 2011. So I think the cardiologist was trying to break one of the laws of thermodynamics. Putting something inside of something that's too small to begin with isn't going to make it bigger. So this is a patient of mine actually from 3 weeks ago, and the option was to blow out the root, do a root replacement with a freestyle with a 23 millimeter, and he's done fine. And that's the specimen that was removed. Interestingly, the leaflets of the core valve there are calcified. They're only 1 year post-implantation. I think that has to do with the fact that it was rammed into a small orifice, because that certainly hasn't been our standard experience 1 year post-core valves. And this study has already been mentioned this morning by the first speaker, but just don't forget that actual aortic valve replacement results, as seen on the right here, this is Todd Dewey's paper from JTCVS, are good, and this should be still considered the gold standard. However, there are certain patients that really do benefit from TAVI, especially the valve in a valve. This is a paper that we published last year from Jörg Kempfert, and out of the 11 that we had at that time, we're up over 60 now, including our transfemoral experience. But of the 11, there was a successful implant in all 11. There was no 30-day mortality. There was no strokes. Other information that's important for us as surgeons, here's a paper from Ferrari in the European Journal of Cardiothoracic Surgery this year, showing what exactly the inner diameter of all the different valves are. Although this is something that we've discussed for, 15 years in cardiac surgery, this seems to be a revelation that a 21 for a perimount does not have the same internal diameter as a 21 for a mosaic. But anyway, this data is out there, it's in the literature, and I suggest strongly that you look at these numbers before you choose which size of valve to implant. I was just in New York last week, and a cardiologist from New York was trying to tell me that they had a 31 epic patient, and they measured on echo 25.9 millimeters in one dimension and 25.3 millimeters in another dimension, which is probably within the error standard of error. But they said we put in a 26 millimeter sapien and were surprised that the patient had a paravalvular leak. And I said, well, shouldn't be surprised. It was a 31 epic, patient needs a 29 sapien. Anyway, complication management, I'm not going to talk about this because I have a talk on it this afternoon. Just to state complications, you have to be prepared for everything. It doesn't matter how talented your interventional cardiologist is, he's not going to get you out of this situation, okay? You need a cardiac surgeon that can quickly split the guy's chest and do bypasses to the LAD and obtuse marginal. So, transapical procedures, I'm talking about that a bit later, so I'm also going to leave that for later. And then finally, the peripheral vascular management problems as a surgeon. These we're seeing less and less. We used to go around showing this picture all the time, iliac artery on a stick. This happens very uncommonly, and I must hand it to my interventional colleagues. They do an excellent job of managing these problems most of the time. Here's one example. As you can see, a very elderly lady, quite brittle, a lot of calcification everywhere, has a rather tortuous iliac artery, and here you can see the introducer is starting to probably leave the wall of the artery, of the iliac artery, which is not good. And then we started to get some hypotension, did an aortography, and here you see a free rupture, just complete disruption of the internal iliac artery, and external iliac artery. And then here they quickly whipped in a covered stent and took care of the situation. No surgical therapy required whatsoever, all handled by the interventional cardiologist. Very impressive. So I think the cardiac surgeon plays an important role in TAVI therapy, most important being decision-making as part of the heart team. Managing complications also a crucial role, which I'll speak about a little bit later. And I think also this is an important point, is that the burden is on us as cardiac surgeons to keep everyone honest in this area of sometimes rather unbridled enthusiasm. Thank you very much.